Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article Treatment-Free Survival, a novel outcome measure of the effects of immune checkpoint inhibition, pooled analysis of patients with advanced melanoma by Regan et al. My name is Adil Daud, and I'm Professor of Medicine and Dermatology and Director of the Melanoma Program at the University of California, San Francisco. My oncologic specialty is medical oncology. Cancer therapy has achieved great success in the last 40 to 50 years. Where treatment with chemotherapy often required inpatient hospitalization and significant toxicity, therapy today can often be achieved with lower grade side effects and limited time in the hospital or in the outpatient infusion center. While these changes have brought enormous benefit to patients, many patients feel the burden of ongoing therapy for metastatic or advanced cancer and long for a time when therapy is not continuing and the word cure is not completely out of mind. Aligned with these concerns is the rise and expansion of immunotherapy for cancer. The growth and spread of neoplasm often triggers the immune system, which mobilizes in response. While cancers use a variety of adaptive mechanisms to evade the immune system, blocking these evasive mechanisms can produce lasting responses and, in some cases, durable tumor-free intervals. Cytokine therapy, as exemplified by interleukin-2, offered this benefit since its approval in the 1990s for renal cell cancer and melanoma for approximately 10 to 20% of patients treated. The CTLA-4 antibody, ipilimumab, had a similar long-term disease control rate with a better toxicity profile. However, it is the anti-PD-1 monoclonal antibodies used by themselves or with ipilimumab that have made treatment-free survival a tangible and achievable goal for many patients with cancer, especially those with cutaneous melanoma. Measuring the effects of treatment is traditionally done with measures of disease control. These include tumor shrinkage, as measured by an agreed-upon method such as RECIST or IR-RECIST, or by lengthening of time, either lifespan or time without progressive disease, progression-free survival. However, it is possible that a similar lifespan could be achieved in one of two different ways, either continuous treatment with a drug or shorter-term treatment that stops within a few months and then the patient has no further treatment. Comparing these treatments that are profoundly different for a patient but similar in terms of standard time of disease control demands new measures that can help describe the benefit of one or the other treatment. In the JCO article that accompanies this podcast, Regan et al., in an analysis of 1,077 patients across two different randomized trials, attempt to provide such a measure. They define treatment-free survival as the interval between time to cessation of immune checkpoint inhibitor therapy and time to subsequent therapy or death. With this measure, the shorter the therapy and the more delayed the need for subsequent therapy or death, the longer this interval is. Combination immunotherapy can have significant toxicities, and while treatment duration can be short, the duration of side effects can be prolonged. Could treatment-free survival be contaminated with toxicity? To address this question, Regan et al. Introduced another endpoint. TFS, with and without toxicity, and partitioned this with persistent and late-onset grade 3 or greater toxicity. These endpoints are illustrated in Figure 1 of the article by Regan et al. Below the familiar Kaplan-Meier overall survival curve is a slice showing survival after subsequent therapy initiation, so factoring in progression. Below this is the TFS without toxicity. Below this slice is the TFS with toxicity, and below this is the time on IO therapy. With this division, the familiar KM curve gives a lot more information and illustrates the difference between nivo-ipi combination therapy and nivolumab monotherapy. While the overall survival is not statistically different between these two treatments, as shown in previous publications, the TFS lets us see what's going on with patients. In figure 4, we can see that in the combination nivo-ipi arm, the TFS mean is 11.1 months versus 4.6 months for nivo alone and 8.7 months for ipi alone. These numbers indicate that TFS alone does not convey the full picture, as ipi beats nivo in this measure due to the short duration of ipi treatment, while extensive previous data, including Keynote 006, show us that anti-PD-1 therapy exceeds CTLA-4 therapy in virtually every other measure of health. If we look at TFS subtracting toxicity, again, ipi-nivo beats nivo handily with 10 months versus 4 months, but again, ipi with 8.5 months slots in the middle. Figures 5A, 5B, and 5C show us that TFS partitioned by grade 3 or greater treatment-related adverse events, grade 2 or greater treatment-related adverse events, or by the use of immune suppressants. To summarize this interesting manuscript, overall survival can be subdivided into TFS and time on therapy, and time following subsequent therapy. TFS can be further subdivided into TFS with or without toxicity using either grade 2 or greater or grade 3 or greater treatment-related adverse events, or the use of immune suppressants. These additional measures give some granularity to the survival and let us see what exactly survival constitutes time off treatment and toxicity, or time on treatment and with side effects. These measures have several limitations. One of the important ones is introducing differences between treatment arms, which by primary outcome measures have no difference by standard PFS or OS. Also, by favoring short duration high toxicity treatments such as ipi over low toxicity, low intensity chronic treatments such as nivo, they introduce value judgments which matter to many patients but need to be understood as such. In oncology, we need to make these value judgments explicit and make the trade-offs clear. Ultimately, though, the importance of TFS and similar outcome measures may be that they encourage this conversation and help our field open up to these issues that may be important to the patients we treat. This concludes this JCO podcast. Thank you for listening.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement. For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.